Hello everybody, our talk today will be about rhinosinusitis. Rhinosinusitis is defined as inflammation of the mucoperiosteal lining of one or more of the paranasal sinuses and or presence of fluid inside the sinuses. It is divided into two main types, the acute sinusitis and the chronic sinusitis. Acute sinusitis means that sinusitis persists less than 4 weeks in duration and is usually secondary to viral or bacterial infection. Chronic sinusitis, on the other hand, mean the persistence of symptoms beyond 12 weeks. Two different terms also had been presented in the diagnosis of sinusitis, which are the recurrent acute sinusitis and the acute exacerbation. Recurrent acute sinusitis means development of 2 to 4 episodes of acute sinusitis per year, with at least 8 weeks between the episodes. As in acute sinusitis, the sinus mucosa is completely normalized between the attacks. Also, we have what's called acute exacerbation of chronic rhinosinusitis, which means that development of acute attack of sinusitis in chronic rhinosinusitis cases. We shall start with acute rhinosinusitis. First, what are the predisposing factors? One of the very important predisposing factors is the anatomical variations that narrow the osteomeatal complex, including septal deviation, paradoxical middle turbinate, Haller cells, foreign bodies, nasal peaks, polyps, or tumors. This CT shows that there is what's called concaballosa. Concaballosa means pneumatized middle turbinate. Okay? Such condition will lead to obstruction of the osteomeatal complex, resulting in development of sinusitis. This CT shows what's called Haller cells. The other name of Haller cell is the infraorbital cell. This is an air cell that's present just in the inferior orbital wall. Also, it might lead to obstruction of the osteomeatal complex, resulting in development of acute rhinosinusitis. In this CT, there is what's called paradoxical middle turbinate, that the orientation of the middle turbinate is paradoxical. Other causes or other predisposing factor for acute rhinosinusitis is the systemic diseases that results in decreased mucociliary clearance, including cystic fibrosis, Cartagena syndrome, immotile syndrome that includes sinusitis, bronchiectasis, and sterility. Ciliary function is also reduced in the presence of low pH, anoxia, bacterial toxins, smoking, dehydration, foreign bodies, and drugs. Example, atropine, antihistamine, and phenylephrine. In addition, patients with immune deficiency also are at risk for development of acute rhinosinusitis. Another important issue is the roots and source of infections. First is the nasal root. This is due to acute rhinitis, which is the commonest, diving and swimming during acute rhinitis, nasal baking for a long time, nasal foreign bodies. The dental root, unilateral maxillary sinusitis, mostly is an anaerobic infection through dental infection of the upper second premolar or first molar tooth. This CT shows the relationship between the maxillary sinus and the teeth. There is, as we know, the floor of the maxillary sinus is related to second premolar and first molar teeth. Also, oroantral fistula after extraction of the upper second premolar or first molar teeth may lead to spread of infection from the oral cavity into the maxillary sinus, producing the maxillary sinusitis. Also, one of the predisposing factors of rhinosinusitis for development of acute rhinosinusitis is the trauma. Traumatic conditions like sinus foreign body, fracture sinus, and sinus ball trauma all are risk factors for development of acute rhinosinusitis. Now we go to the pathogens of acute rhinosinusitis. Viruses, for example, upper respiratory tract infection viruses, which include rhinovirus, influenza, and parainfluenza viruses, can produce acute rhinosinusitis. The most common bacterial pathogens in acute sinusitis are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. In addition, anaerobic organisms resulting from a dental source also might be a risk factor or a bacteria that leads to acute bacterial rhinosinusitis. Moreover, nosocomial sinusitis is caused by gram-negative organisms like Pseudomonas aeruginosa, Escherichia coli, and other gram-positive organisms and fungi. Clinical picture. The symptoms. First is the general symptoms, including fever, headache, malaise, anorexia. Local symptoms. The first one in the local symptom is the facial pain, which is severe throbbing pain, increases by straining and leaning forward. In case of ethmoidal sinusitis, it's located between the eyes, while in the maxillary sinusitis, over the cheek. In frontal sinusitis, over the forehead, and in sphenoidal sinusitis, it is retroocular and occipital. This picture shows the location of each sinus, and accordingly this will determine the location of the facial pain in case of acute rhinosinusitis. Also, other symptoms include nasal obstruction, nasal and postnasal discharge, which is mucopurulent or purulent, hyposmia, and anosmia. Sinusitis of dental origin are characterized by presence of offensive nasal discharge, cacosmia, and is most commonly due to infection of the maxillary teeth by an anaerobic organism, most probably of the upper fifth and sixth molar teeth. Signs. First, there is tenderness and redness over the affected sinus. In case of ethmoidal sinusitis, it will be over the medial canthus. Maxillary sinusitis will be over the cheek. Frontal sinusitis over the floor of the sinus. Anterior rhinoscopy will show swelling and congestion of the nasal mucosa. Also, mucopurulent or purulent discharge in middle meatus in case of anterior ethmoidal maxillary and frontal sinusitis. In superior meatus in case of posterior ethmoidal sinusitis, and in sphenoethmoidal recess in case of sphenoidal sinusitis. This picture shows the anterior rhinoscopy where I am using a nasal speculum to open the nasal cavity and look for the signs of acute rhinosinusitis. Also, both nasal purulent and mucopurulent discharge might be seen. In addition, endoscopic examination will reveal the origin of the purulent discharge and may provide information about the nature of the osteomeatal complex. This picture shows an endoscopic view of the middle meatus where pus is coming down through the middle meatus, and this was typical to the what's seen in the CT coronal view in the same picture. Differential diagnosis of acute rhinosinusitis. It should be differentiated from upper respiratory tract infections, allergy, and vasomotor rhinitis. Also, it should be differentiated from migraine and trigeminal neuralgia, either primary or secondary to dental infection and sinus tumors. Investigations. Radiological evaluation in doubtful or complicated cases by doing plain X-ray of the affected sinus showing mucosal thickening, air fluid levels, and sinus opacification. CT is excessively sensitive. Also, culture and sensitivity of the discharge from the sinus is the only definitive way to diagnose infectious sinusitis. This is an X-ray view of the paranasal sinuses. Treatment. We shall start by medical treatment by giving antibiotics. The duration of treatment is usually 10 to 14 days. The first line therapy is usually amoxicillin clavulanic acid, macrolides in patient allergic to penicillin. Second generation cephalosporin respiratory quinolones including levofloxacin and moxifloxacin are also effective. In addition, analgesic and anti-inflammatory drugs for pain and edema could be prescribed. Use of vasoconstrictors, either systemic or local, will decrease the congestion and thus help in the drainage of the sinuses. Antihistamines are beneficial in patients with allergies and acute sinusitis. Surgical drainage. This is indicated after failure of medical treatment or the presence of threatening complications. Achieved with functional endoscopic sinus surgery, this is the operation of choice. Traditional surgical treatment to promote drainage of the affected sinus: medullary sinusitis puncture and lavage, frontal sinusitis external trephine of the floor of the sinus. This picture demonstrates how endoscopic sinus surgery is done. This is done via a nasal endoscope. Now we go to the chronic sinusitis. Definition: it is chronic inflammation of the mucosal lining of one or more of the paranasal sinuses. Chronic sinusitis is the persistence of inflammation within the sinus beyond 12 weeks. Predisposing factors. Inadequate treatment of acute sinusitis due to virulent or atypical organisms, or inappropriate selection or short course of antibiotics. Local predisposing factors, including anatomical variation that narrow the ostium area, example deviated septum or large middle turbinate, mucosal disease, example allergy, polyposis, mucosal transport disease. Adenoiditis or dental infection leads to chronic maxillary sinusitis. Disturbed mucociliary clearance in case of cystic fibrosis, immotile cilia Cartagena syndrome that includes sinusitis, bronchiectasis, and sterility. Systemic causes include poor immunity, for example diabetes mellitus, prolonged corticosteroid therapy, and environmental factors, example smoking and pollution. Causative organisms are either aerobic, including coagulate negative staph, are the most common, and the anaerobic organism in 2 to 20% of cases. Symptoms: first is the nasal obstruction and anterior nasal discharge, which is mucopurulent or purulent and may be fetid in case of dental maxillary sinusitis. Both nasal discharge with irritative cough are also present. Facial pain is localized and dull aching pain over the affected sinus. Very important characteristic of chronic rhinosinusitis was called the vacuum headache. This is characteristic for frontal sinusitis. The pain is maximal in the morning and decreases gradually over the day. The cause may be due to closure of the sinus ostium helped by congestion of the head due to lying down with absorption of the air from within the sinus cavity. Erect position during the daytime gradually relieves the ostial obstruction, leading to headache release. Symptoms of descending infection including otitis media, pharyngitis, laryngitis, and bronchitis. Symptoms of septic focus including low-grade fever, headache, rapid fatigue, and arthritis. Signs. Nasal endoscopy is essential for all patients with symptoms suspecting chronic rhinosinusitis. You can see congested edematous nasal mucosa over the turbinates, mucopurulent or purulent discharge in middle meatus and anterior groove sinusitis, superior meatus to posterior ethmoiditis, and sphenoethmoidal recess in sphenoiditis. Nasal polyps may be present in the middle meatus in chronic ethmoiditis. Investigations. Radiological examination by doing computed tomography scanning, which is the gold standard for diagnosis of chronic sinusitis. The aim is to determine the extent of pathology and to delineate the anatomy in patients undergoing surgery. Plain X-ray is no longer performed for diagnosis of chronic sinusitis as it is poorly demonstrates the ethmoid and frontal recess. Culture and sensitivity tests of the discharge also can be done. This study shows frontal sinusitis, ethmoiditis, and the maxillary sinusitis. Differential diagnosis from fungal rhinosinusitis and from tumors of the nose and sinuses. Treatment. Medical treatment by giving systemic antibiotics for 3 to 4 weeks to cover both aerobic and anaerobic organisms. Nasal decongestant by alkaline nasal wash. Intranasal corticosteroid spray may also be beneficial. Surgical treatment. This is indicated in failure of medical treatment or the presence of threatening complications. It's carried out by functional endoscopic sinus surgery. This is the operation of choice because it restores the ventilation and drainage of the affected sinus through its natural ostium via correction of all abnormalities in the middle meatus as infected ethmoidal cell, polypi, and enlarged middle turbinate, widening of the natural ostium of the affected maxillary sinus and frontal sinus. No direct intervention is performed on the diseased sinus mucosa and the diseased sinus mucosa. It subsequently returns to its normal functioning state. Types: middle meatal antrostomy for maxillary sinusitis, ethmoidectomy in case of ethmoiditis, ethmoidosphenoidotomy in case of ethmoiditis and sphenoiditis, frontal recess clearance in case of frontal sinusitis. External approaches for maxillary sinusitis. This is usually carried out by repeated puncture and lavage of the maxillary sinus intranasal antrostomy. Radical antrum operation called Willux is rarely indicated nowadays because it promotes drainage of the affected sinus through an artificial opening, not the natural opening. Ethmoiditis is surgically treated by doing what's called external ethmoidectomy, which is rarely done due to facial scar. Ethmoiditis is usually managed by sinusitis or external ethmoidosinoidotomy. Frontal sinusitis by external frontal operation using osteoblastic flap via coronal or brow incision. This photo shows how Caldwell-Lux operation is performed and the site of opening usually at the level of the canine fossa. This is a true photo for Caldwell-Lux operation. This is what's called the lateral rhinotomy approach. Actually, it was previously used, and in such condition, we have to uh, make sure that this operation will leave a very ugly scar. So this operation is no longer used now, and instead of it, the functional endoscopic surgery has replaced this ugly scar. Thank you very much for your listening.